Gary, doctors say an apple a day, but what do doctors know? So my presentation, which is what a life with a Fontan, what doctors do and do not know. I think it'd be fair to say that the list of things we don't know is longer than the list of things we do know. And I feel this presentation is an introduction to a lot of the other talks that are being given throughout the course of today, because it's a goal of the Fontan Registry to reduce the length of that list of things we don't know. So I think what we do know is that in the current era, patients with a Fontan circulation have excellent long-term survival. We also know a lot of factors that impact on early and therefore overall survival. Some of the things that David Winlaw was speaking to. These things relate to the underlying cardiac diagnosis, the selection of patients going through the journey towards the Fontan circulation, and technical factors and perioperative care. All have had a significant improvement on overall survival. We know that. But I think now that we're in an era of improved survival, we need to move beyond just improving survival. And the focus, therefore, falls on promoting a healthy, happy, and productive life. However, I'm sorry to say that our knowledge at the moment about how to promote this in patients with a Fontan circulation is incomplete. So a little bit of background about how doctors get to know things. Medical knowledge is built up often over a considerable period of time, but in many different ways. And our goal always should be to use the best available evidence to guide treatment for patients with various conditions, including those with a Fontan circulation. As a medical practitioner, I look at the medical evidence and often rate or rank the medical evidence on its strength. And there's a hierarchy of this strength of evidence. This begins with an expert or experts giving an opinion, through to short reports on a small number of patients and their outcomes, through to reports of patients comparing those with those who don't have the disease or not exposed to a particular treatment, through to larger cohort studies, which is a larger collection of patients and their data is gathered together to inform about treatment and outcomes. And the highest level of evidence that we usually rate is what's called a randomized controlled trial, or a double-blind, placebo-controlled randomized controlled trial, where patients who have very similar characteristics are randomized or allocated to groups where, if it's a treatment trial, neither the patient nor the investigator knows which of the treatment is being given, and then outcomes are measured. In the field of Fontan circulation, most of the evidence falls here in terms of case reports, case-controlled studies, and cohort studies. And the Fontan Registry is, as we've heard, the largest cohort study or registry-based study of patients with a Fontan circulation in the world. There are barriers to performing randomized controlled trials in patients with a Fontan circulation. So we've heard that all Fontan patients are different. They have varying underlying cardiac diagnosis. They have variable types of Fontan circulation. And this makes designing a randomized controlled trial quite difficult. Randomized controlled trials are very costly. And even in multi-institutional studies, the number of subjects that you can allocate to a treatment in a randomized controlled trial is small, therefore limiting the conclusions that can be obtained. Furthermore, in randomized controlled trials, particularly in Fontan patients who often are well and remain well for long periods of time, it's hard to pick a meaningful health measure to monitor. And therefore, surrogate measures are used. And it's not clear how surrogate measures relate to important health outcomes. Another barrier that is potentially an issue is reluctance from patients or parents or their doctors to participate in randomized controlled trials, but usually that's not an important factor. However, the difficulty in performing randomized controlled trials highlights the importance of comparative effectiveness research, so comparing outcomes using observation in well-designed large registries such as the registry we have here. So what do we know a little about in patients with a Fontan circulation? So we know little about the medications that may help heart function, and there'll be more talk about that, but that relates to things like angiotensin conversion enzyme inhibitors, pulmonary vasodilators, which are medications used specifically to lower pressure in the lung arteries. We don't know what the long-term effects of having a fenestration are, and we don't know what effect lifestyle factors which influence acquired heart disease, what effect that has in Fontan patients. We don't know the long-term effects of a Fontan circulation on the lungs and the breathing muscles, and we don't know things that can be done to maintain healthy lungs. We don't know as yet the long-term effects on kidney function, although there is some evidence being developed around that. And we don't know things that can be done to maintain healthy kidneys. We don't know the long-term effects on liver function and how to maintain healthy liver function in the long term. We have only a very limited idea about the effects of a Fontan circulation or the journey to that point on quality of life and the clinical, psychological and sociodemographic determinants of quality of life. We don't know the optimum form of prevention of clots, with clots being a risk factor for stroke and poor circulation. We don't know what modifiable risk factors there are for poor neurocognitive development, and we don't know the best ways to screen for that. In terms of exercise, we don't have a clear idea about what exercise would be appropriate, what exercise should be restricted in patients with a Fontan circulation, what should be prescribed in patients with a Fontan circulation. And we have limited information about the long-term health benefits of physical activity. In terms of pregnancy and contraception, we don't have clear evidence about optimal forms of contraception. We don't have clear idea about ways of increasing rates of fertility in female patients with a Fontan circulation, reducing rates of premature delivery, or optimizing pregnancy care. So how are we going about improving that level of evidence? So as part of the Fontan Registry, we undertook a systematic review of what evidence there was available. And systematic review essentially means a group of people looking at all the evidence in the world that has been collected on a particular topic or topics. And we've recently completed this. I won't go through all the findings, but I'll focus on one or two aspects. So one aspect which Karen mentioned is an ongoing research area of research interest is aspirin versus warfarin. Looking at the retrospective or retrospective cohort studies, by and large aren't helpful to tell us whether aspirin or warfarin is superior or inferior. There's one randomized controlled trial performed in Melbourne and published a few years ago on about 50 patients on warfarin and 50 on aspirin. And there was no significant difference in terms of the prevalence of thromboembolism in each group, and taking aspirin was easier to do. In another study looking at the same group of patients, it was found that those patients on warfarin who had significantly low levels of blood thinning had higher rates of thrombosis than those who had an ideal range of blood thinning, and that although major bleeding events were not more common in those on warfarin, minor bleeding events were. So you could say from this randomized controlled trial that it would be reasonable to recommend long-term aspirin therapy. I don't think you can stop there, and hence the Fontan Registry is looking further in the functional outcomes study as to whether this holds true. So what do cardiologists do across Australia and New Zealand? We undertook a survey of cardiologists on a number of aspects of long-term care. Predominantly in the early period after Fontan completion, cardiologists recommend warfarin. And then in the longer term, a slightly greater number recommend warfarin than aspirin. However, a lot of that is individualized according to the perceived risk of patients for thrombosis. So that if you had a fenestration, a greater number of cardiologists would recommend fenestration, and so too with the AP Fontan. What about medications to support heart function? In a systematic review, we found that there was no conclusive data to support the routine use of ACE inhibitors in Fontan patients, and that's medications such as enalapril, captopril, lisinopril, many of which you've heard of before. Now, why do we use it then? Well, it's largely based on clear benefits shown in adult patients with acquired heart failure, and we've more or less extrapolated that into children and adults with a Fontan circulation. And that may be reasonable to use in some patients with a Fontan circulation who have impaired heart function or leaky heart valves, if we can demonstrate that it's safe and tolerable. So what do cardiologists, why do they recommend ACE inhibitors? Mostly it's for those indications that are used in adults. Heart muscle weakness or leaky valves inside the heart. And this data generated from the registry by a medical student that was supervised by Eve suggests that when you go back through the Thomas, thank you. If you go back through all the files of medical records of patients with a Fontan circulation, and Thomas did that in over 1,200 cases, over 36% or over a third were on ACE inhibitors at their last follow-up. And we tried to tease out what their indications for being on the ACE inhibitors were. Many were on those indications that I mentioned, which is heart muscle weakness or valve regurgitation. But many, it wasn't clear what their indication for being on ACE inhibitors were. So where to for medications that help heart function? As I said, you could do a randomized controlled trial, but that is going to be difficult to design and undertake. I think where we go is more detailed documentation in our clinical practice of the indications for use, the health status of patients before and after use, side effects of medication, and patient tolerability. In terms of further evidence that we've accrued within the Fontan Registry, timing of Fontan conversion. So patients with an AP Fontan, as described by David Winlaw, if they're not doing well, if their right atrium is dilated and they have heart rhythm disturbance, it's possible to convert that type of Fontan into either a lateral tunnel or an extracardiac conduit. So what are the results of that or outcomes? So in our systematic review, we found that for reports where there were more than 10 subjects reported with Fontan conversion, and there were 416 such patients, there were 26 early deaths, 26 late deaths, and 9 subsequent cardiac transplants. The risk factors for death after Fontan conversion were an RA to RV connection, which is an old type of Fontan, older age at conversion, preoperative, more severe valve regurgitation, liver abnormalities, protein losing enteropathy, the presence of a morphological right ventricle rather than a left, and prolonged bypass time. The operative survival after Fontan conversion varied between about 87% and 99%. In a study published from Registry data recently, there were 39 Fontan conversions at 6 centres, and it just happened that one centre had a policy of converting patients earlier than the other centres. And that was a unique opportunity to study, in essence, a natural selection process. And it was found that outcomes in the centre performing earlier Fontan conversion were better than those in the other centres. So what do doctors know and what don't they know? There's much that we don't know about the Fontan circulation, but we're making progress to learn more. And as Eve said, it's important for families and patients to be involved in the process of coming up with questions that need answering. It's going to be difficult to design randomized controlled trials, but much is being learnt from large registries such as the registry we have here. So thank you.